has been there for quite a while, for about 6 to 8 weeks. There's some non-specific symptoms. But all the other differentials are, as you said, is within reason. The only thing here is that I don't think it's as vascular as what I like the others to be. And this is quite homogeneous. And then the other thing I'll be thinking of is the head and neck. Sorry?
I can go to the parotid gland tumor, polymorphic adenoma also.
Sorry? Again?
Parotid space tumor from parotid gland on the right side is solid. So I can add the polymorphic adenoma from parotid gland.
Yeah, that's true, but often those are a little bit more in the adult population than the children's population. Yeah, so which is why, yes, these are all different shows. What I'm trying to say is that in head and neck, all of these are reasonable different shows, but it's really what's more common. And so in this case, the two things that came to our head is this rhabdomyosarcoma, because in pediatrics, this is quite common. The other thing is lymphoma. Not to say that all the others aren't, but it's just that because we are looking at the pediatric population. If you're looking at the adults, then that would be within reason, okay? So this was lymphoma. And I've this reason because I've only shown you part of the story. I haven't shown you the other parts of the history, the other form of imaging. So it's just on CT, just showing you it's quite homogeneous. And also because lymphoma is one of the third most common pediatric malignancy. You've got 50% associated with your Epstein-Barr virus. And in X-ray, we know you're looking at the anterior mediastinal mass. You're thinking of the 4 Ts. But of course, the thymomas and the thyroid cancers are not the ones that are really as commonly seen in pediatrics. Not to say that they're not. The other things to think of is a teratoma. Okay, but we are of course looking for evidence like it's more anterior mediastinal. This is very more towards the neck side. And of course, you're something more anterior mediastinum, then we are looking at in your more classic lymphoma, then you think of diffuse thymic infiltration, but also a big normal thymus can look like that, particularly in the younger population. So something that we do is we can use ultrasound to differentiate whether your thymus is a normal thymus, that's just a bit big, or is this one that's infiltrated. Lymphoma is the same as an adult, the way we use CT to diagnose. So we don't really go to MR unless we think that this is not lymphoma. And I think the reason why we didn't think it was the other differentials that you mentioned is because it's quite homogeneous and we didn't think it was particularly vascular, like avid vascularity. You use PET and CT for staging and follow-up, your Ann Arbor classification staging, and of course, complications is airway compression. And in fact, I think one of the studies said 40% of patients with lymphoma, mediastinal lymphoma, actually present with respiratory symptoms. So just a little bit about lymphoma. You've got your classic ones, which is your Hodgkin's lymphoma. Then the other one is the non-Hodgkin's, including Burkitt's lymphoma. These are the two common ones that we see. As I said earlier, the other thing to think of is a normal thymus, okay, but it's enlarged. The other thing is rhabdomyosarcoma. So whenever I think I see a kid with a head and neck lesion, the two things I think of first, other than a glomus tumor, would be a lymphoma and rhabdomyosarcoma. Okay, I'm not saying that the others can't happen, but I think these are the more common ones to just keep in the back of your head. Okay, so another thing that we tend to look for, so in kids, especially lumps and bumps, we always get them to be ultrasound. So a lot of people say lymphoma can be, you can suspect lymphoma with ultrasound. Notes, how the notes look like. Unfortunately, this is the case. This is true for adults, but in children, this is less likely to be so, okay? Because lymphadenitis or reactive lymph nodes, due to whatever reasons, can look very similar. Some people say peripheral vascularity makes it more suspicious, but I think that's difficult because this case is lymphoma. Reason why they are unwell with paralysis.
Recording in progress.
Keratopathy in that region as well?
However, I don't see any lymphadenopathy enlarged in the level 2 lymphadenopathy submandibular. I don't see no lymphadenopathy seen in this submandibular region. So exclusion for lymphadenopathy. We'll exclude it from the differential.
Okay. And what do you think about this region in front here?
In the front here of this
Yeah,
region?
in the, just sorry, can you see my pointer?
Yes, yes, I see this in the base of the tongue. I think there is, in this anterior part, I see there is some high signal thickening of the mucosa, of the pharyngeal mucosa anteriorly. This could be, but however, this is bilateral seen in both sides. Could be this, to arrange, could be this pharyngeal in this young age. I will worry about tonsillar hypertrophy. If this adult age enough, I will suspecting nasopharyngeal carcinoma, and this could be metastatic lymphadenopathy from here. However, this one in the other side, or cerebral gland tumor. This one could be cerebral, but I'm expecting this of the patient.
So this patient is 5 years old.
Okay. For 5 years old, I will exclusion the germoplastic cause. I will go more with lymphoid hyperplasia or inflammatory causes, and this could be as I said, could be this is lymphadenopathy from this one.
Okay. So this was a rhabdomyosarcoma. As I said, I agree with your differentials given the location, but I think, I mean, this is what we've been taught, or I've been taught as a fellow. If we are looking at head and neck tumors, I mean, I would accept what you said, your neurofibromas, because I think there's a site where you've got your vagal nerves there. I think I would accept your what you said of lymph. I didn't think you didn't say lymphadenopathy. You said salivary gland tumors. Again, I'm not sure they happen. So, I mean, again, they do happen in kids, but it's not one of the common ones that happens in children. You also mentioned stuff like a carotid body tumor, but often they have this salt and pepper appearance, which I'm not seeing here. And what bit that I was pointing to you here was that there's a little bit of, this is on the T2 fat sequence. I thought there was a little bit of a probably necrotic tumor here. As you can see, this rim, this is on the post-contrast and with your central low signal. So this turned out to be a rhabdomyosarcoma. Okay. It was on ultrasound. We saw this, we were worried. The other thing was, again, I said it was this lymphoma, okay, like some sort of Burkitt's lymphoma, because they are very common in the head and neck. And so, which is why we decided to do in the MRI. I mean, MRI, there's nothing specific to say this is definitely a rhabdomyosarcoma until the histology, which is what we eventually the tertiary hospital did, and it turned out to be a rhabdomyosarc, but then these were differentials that we put inside. Okay. I would accept your neurofibroma, as I said, your lymphoma. It's, yeah. Because of the age, I'm not thinking of something like infantile hemangioma, because the only things that on ultrasound also I would expect to be a bit more vascular, although it's quite well defined. So these, and that could be one of different shows as I've written, but I think the ultrasound characteristics go against it. Okay, but carotid body tumor and glomus tumor, I think that's for an older population than a younger population. All right. So it's actually quite common. In fact, the most common soft tissue sarcoma. Okay, 70% below 12, 40% below 5. Okay, so and up to 40% of them occur in the head and neck. Of course, the associations is you've got other syndromics. You've got a Noonan syndrome, or you've got previous radiation that increases your risk. There are 3 for rhabdomyosarcomas kind of thing, or tumors from primitive mesenchymal stem cells, such as rhabdomyoblasts. You can have 3 different histologic subtypes. You've got your embryonal ones, which is the most common in young children, which is on WAS. You've got the alveolar rhabdomyosarcoma, which is in the 15 to 25 years old, and then the later older ones, which is the pleomorphic ones, which is about 40 to 60 years old. Okay, so ultrasound, you've got a very firm mass with a very variable internal vascularity, but hemangioma is often very, very vascular, like we see from last week. You've got a soft tissue mass can be invasive, but not always, okay? It can be quite well circumscribed, which you have here, not always associated with bone destruction. Of course, you're thinking of something that's infective, then you're thinking if it's near bone, then you have a lot more inflammatory changes, but this is actually not too bad. And it of course restricts this diffusion because it's quite a solid tumor. So I said earlier, the other things you can think of is lymphoma, infantile hemangioma, and plexiform neurofibroma. But people say if you've got plexiform neurofibroma, you expect to see more sites, so not a single site. And also you can have some target sign to help you differentiate between neurofibroma or schwannoma. But later on, it's actually, you can't really characterize it as well. Okay. So, yeah. Okay, so and of course, if you have thinking of neurofibroma, you want to find out if you've got any history of neurofibromatosis. Okay, next case.
Okay. This is an MRI of infant, and I see there is a sagittal T2 view. There is mass intermedia here showing homogeneous signal in this below the third ventricle. In T1, it is homogeneous signal here. In the other axial view in the flare, I see there is high signal in the region of the third ventricle with lobulated border. In the other anterior, I see there is supracellular lesion here with high signal, homogeneous high signal in the flare with heterogeneous anteriorly. So in comparing, there is no evidence of syphilis. So I'm warning about this mass in the supracellular region anteriorly, and as well as it's going to third ventricle. This one.
Okay.
So the supracellular region mass in center, the first female, it is could be a germ cell tumor. In this region also Craniopharyngioma, as well as Essex graft cyst. However, this is cystic solid lesion.
Mm-hmm.
And also CCL is normal, so exclusion for pituitary macroadenoma.
Okay, so of the three that you've given me, well done. That's the different shows I have on my list. That's very good. So what do you think is most likely? You said solid cystic tumor, midline, near the region of the cellar, supercellar.
Okay, I will go with craniopharyngioma more for me.
Yep, well done. So that's a craniopharyngioma. As what you mentioned, you've got a cystic component here, which is not really that of CSF density. You can see it's just slightly higher than compared to the CSF, and you've got a solid component that you can see here on the flare, and also with some enhancement on the T1 post-contrast study. Okay, good. So this is a craniopharyngioma. There are two types normally. You've got in the kids one, you've got the adamantinomas, so it's mixed cystic solid, and of course you've got another one which is mostly solid. It's adults. It's squamous, called squamous papillary. Okay, it's a benign, historically benign tumor, and it rises along, or whether I always think of it near the pituitary region, so hypophyseal, rectally duct. You do see it, the peak age is 8 to 12 years old, and it's very common. So over 50% of the pediatric supercellular tumors, you can see in that location, almost 60% or 2/3 of it would be, or craniopharyngioma happens more 60% in about cellular supercellular region, okay? And of which half of it is in the supracellular. And there is a rule that says if you've got on CT, 90% cystic, 90% calcified, and 90% enhanced, and it's the wall and the solid components that do. And cystic components are T1 hypertension, as we saw earlier. It's quite different from the CSF. And then you've got variable T2 signal. And I think the best diagnostic tool that I always think about it's a cystic supracellular mass with calcification, which we don't really have here, but there's an enhancing solid component. So you mentioned germ cell tumor or germinoma, we will go through later, not really a pituitary adenoma just because of the location. And then the other thing is Rectal cleft cyst, and how I think about it is that you don't really have the calcium in Rectal cleft cyst, and often it's more cystic rather than cystic solid components. Okay. Okay, next case.
Okay, I have provided by multiple sets of the MRI. The first one in left, it is flare image axial. It's showing there is mass in the region of the pineal body, which is showing high signal with rim of edema surrounding it. And also there is a transvendimal high signal in the perpendicular. Could be this from increased hydrocephalus increased pressures. And this one here, I see this. Okay, and the in the restricted diffusion weighted image, I see the lesion doesn't showing restrictions. It's the same low signal. In sagittal T2, I see the lesion is usually condensed to the region of pineal body. In T2, flare the same. In contrast, showing homogeneous enhancement. So I will be going with the pineal body tumor, pinealoblastoma, as this one. Is also differential for me. It is germinoma as well as germinoma. Okay.
Yeah, so good, well done. Yeah, I've got the same differentials as you, so you can see here that's on that's flare. You've got this heterogeneous lesion here, and you can see that on the cyst sequence, it's your DWI ADC. It's probably very mild degree of restricted diffusion, okay, because slightly high and then low on, there are certain high and low areas on DW and ADC. And on the cyst sequence, which allows you to see CSF, there is at the cistern, you can see that there's obliteration of it, and so with resultant prominence of the hydrocephalus of the lateral ventricles, and it's quite heterogeneously enhancing as well on the T1 post-contrast sagittal. So this is a germinoma or germ cell tumor, but perfect in terms of your differential diagnosis. It's very common in the midline, so 80 to 90%, pineal more than suprasellar region, often happens in a young child. And I think if I've shown you the CT, what it shows is that it always engulfs the calcification within the pineal gland, because you can get calcification there. And if it happens in a suprasellar cistern, then your infundibulum looks a bit bulky. Okay. Very variable signal, so about high ISO to hyperintense on T1, and variable on T2 as well. And you've got that homogeneous enhancement is slightly heterogeneous with areas of non-enhancement, but the enhancement is quite strong. And because of high cellularity, you also get a degree of restricted diffusion. And with germ cell tumors and a few other of the tumors that we're going to discuss later, you need to image the whole neuroaxis to ensure that there's no CSF spread. And I thought from there, it's good to just revise. This is something that can help you to differentiate between the pineocytoma, pineoblastoma, or germinoma. They often talk about, I can't remember if you remember for your 2As, but they always talk about how it looks like the calcification looks like if you've got a lesion there. So a germinoma, often the calcification is central. Pineocytoma is one is more benign category of pineal tumors, and this is an exploded calcification appearance you can see in the middle. So it's kind of more circumferential, or pineoblastoma, it's peripheral and quite focal. Okay, but in terms of how it looks quite similar to germinoma, but the location of the calcification, it's the key differentiating factor. Okay. Okay, next case.
Okay, I have provided by multiple set of the image. In the first one above, it is T2, showing there is right temporal lobe, cortically based focal space occupying lesion with high signal intensity. In the flare, the lesion showing intermediate signal. There is no significant perilesional edema. In coronal view, I see it is also in the temporal lobe. In the restricted diffusion, I see the lesion showing high signal, doesn't showing restriction here. In contrast, this doesn't contain taking contrast. So I will going with tumor in this region. I will give ganglios confirmed for this region. I will go for ganglioneuroma, gangliocytoma, as well as exansomatous astrocytoma in this region. It's more common in this temporal lobe. However, I don't see any cystic lesion for exansomatous astrocytoma.
Sorry, so if you just tell me your top different shows again.
Gangliocytoma in this region, and also exansomatous astrocytoma and the Dennett.
Sorry, what's the second one? I think for me you keep dropping out. So you called DNET, you talk about ganglioglioma, and what was the second one?
Exansomatous, polymorphic exansomatous astrocytoma.
Okay. I'm not sure what that one is, to be fair. Okay. Again, I am not, as I say again, I don't know what the second differential is. I have to be quite frank. So this is a DNET, okay. I would go with the differentials for me would be a ganglioglioma. I really don't know what the second differentials that you gave was. What is it again? Can you just read it slowly?
Exansomatous astrocytoma. Exansomatous.
Xanthomas. Okay. I always thought those were more, is it? Yeah, okay, astrocytoma, yes. I call it a PZA if I'm not wrong. And that's often one of the ones with cystic tumor with a solid enhancing mural wall is one of the things I think of. So which I don't see here. Okay, so this is a DNET. So it is, I think before I go in there, I think what to take away from here is that if you guys haven't done PEDS before, and I can tell you I'm not a neuroradiologist, often imaging, you can only come up with a list of different shows until they get discussed in a neurology MDT where the radiologists are a bit, they see these tumors day in, day out. They can correlate with other more subspecialist techniques such as MRS spectroscopy. Or even when they take it out histology, then you can say exactly what it is. So for the purpose of the exam, what I want you to go away is not to think, I need to learn all these tumors, but to have the top 3 different shows of, let's say, cortical-based pediatric tumor supratentorial. Okay, because you cannot remember all of these for the exams, and you remember this is just pediatrics. You also have the other specialties to think about. Okay, and pediatric neuroradiologist is a subspecialty. So which is why I've just chosen a key learning points that I want to highlight. Okay, yeah. So anyway, this is a DNET. It is one of the things that they can show you. It's it causes epilepsy. Okay, I can't pronounce the word today. Epileptogenic. No, I've done it. Epileptogenic, and it's a benign tumor. And often it gives you partial complex seizures, and reason why it's good because it's almost exclusively cortical, okay? And there will be some history of seizures, which makes you narrow down and say, okay, I'm thinking of cortical-based epileptogenic tumors such as DNET. Temporal more than frontal, I'll just think temporal region. And the other thing to think of is something ganglioglioma can look very similar, okay? But often it's a bit more cystic, mixed cystic solid. So, but coming back to DNETs, you get, it can be hyper intense on T2, like what we see here, quite a large area, or you can have many small cysts, quite bubbly mess, but we're not seeing that pattern here. You can have very variable enhancement, okay, and you don't always have the restricted diffusion, okay, because it's it's not a very cellular lesion. Good thing is that METs or malignant tumor transformation is very rare, so often they go in, they can take it out. The only thing is that it can come back again. Okay, so for cortical-based supratentorial tumors, which causes seizures, you are thinking of a DNET or a ganglioglioma. Okay. Okay, case 6, next one.
Okay, I have provided by multiple sets of image of CT. There is hydrocephalic changes seen as also dilated temporal hole. There is posterior fossa space occupying lesions confined to the region of ventricle with slightly hyperdense, homogeneous heterogeneous outline, hyperdense compared to the brain parenchyma. This is a case of medulloblastoma with hydrocephalic change. Did urgent refer for neurosurgeon for shunting or to relieve this hydrocephalus. The region medulloblastoma is also differential for me. It is ependymoma. However, ependymoma usually is showing extension to the from magenta from Blashka, and it is more regular outline. It is tooth-based tumor. This medulloblastoma, I will advise to do imaging for access to excluding droplet nets of the spine. Okay, I will refer the case for the brain tumor MLT. This is medulloblastoma.
Okay, good. So I think we are now coming to a bit more classic things that you see. So this medulloblastoma is classic posterior fossa tumor. Okay, one of the big three, I think. So it's a malignant, highly cellular, so very dense, which is why it's quite hyperdense on CT. Of course, restricted diffusion. So medulloblastoma versus your ependymoma, one arises from the roof, so medulloblastoma, the other arises from the floor. Often you can't tell, but if anyone here is trying to see the 2As, then that's one thing that they may ask you. The thing here is that if your child is quite young, and if I'm saying below 3 years old, and you've got to think about ATRT, okay, there's no ATRT versus medulloblastoma. You don't really see much of the differentiating imaging features, just that ATRT can be more homogeneous. A bit more medulloblastoma that you may not know. So there are 4 major molecular subgroups. Because there's this whole neurogenetics about tumor staging as part of improving treatment. So there's the wing or WNT subtype. You've got the sonic hedgehog subtype, group 3 and group 4. Okay, it's not something they'll ask you, but it kind of explains why sometimes the medulloblastoma can look very heterogeneous. Okay. That's because there are different subtypes, and of course a different prognosis from these as well. And like what candidate one rightly said, your different shows is ependymoma as well, which we'll see a case later, and the other thing to think of is a brainstem glioma, but then that's in the brainstem, and this is clearly not within the brainstem, it's kind of within fourth ventricle. Okay. When you see medulloblastomas, you have to image the entire neuroaxis to look for CSF spread. And interestingly, which I think I mentioned in the last MSK talk, they do have extra neurometastases, okay, in which they look sclerotic on the bone. Okay. So just to show the different subtypes, WNT, sonic hedgehog, group 3 and group 4. Okay. So another example of medulloblastoma, I won't fault you if you said you thought this was ATRT, and this just shows you all the metastases in different parts of the brain. Okay. Okay, next case.
Okay, I have provided by brain MRI in the upper one T2 showing there is mass in the fourth ventricle with regular border. In the second image showing this mass extension through the extension to the caudal to the fourth more fourth ventricle. With possibility of extension to the foramen of Loschka, as well as Magini. In the restriction, the mass doesn't showing high doesn't minimal restriction. Merely however it's heterogeneous in contrast enhancement. In the sagittal view, I see the extension through the foramen of Magindi. So this is a case of ependymoma.
That's right. So well done. Yeah. So that's the other one in the same region, but as candidate 2 has, candidate 1 has said, it's a lot more plastic. So it goes kind of around through your foramen Magendi into your from the cisterna magna into your cisterna magna, and then the other one is from a Luschka into your CPA angles. Okay. So versus medulloblastoma, it comes from the floor, while the other one comes from the roof. You sometimes can get a bit of fine stipple calcification, but better seen on CT, but we don't have that, so we've got MR. And restriction diffusion really it depends on the grade of the tumor, okay? Similar to medulloblastoma, there are also 3 different subtypes, but we're not going to go into that here because often the subtypes are more talked about in medulloblastoma than in ependymoma. And like ependymoma, like in medulloblastoma, you need to image the whole neuroaxis to make sure there's no, to rule out any metastases. Okay, next case.
Okay, I have provided by multiple set of MRI. In T2, I see there is bulging of brain stem and bones and the bones. There is a slight hypersignal in the middle. And the other slight high signal, it is likely to nearly to be homogeneous high signal. In failure, this is also showing high signal with foci of low signal in the left side. In restriction, doesn't showing restriction minimal anteriorly. In this sagittal T2, it was a high signal, and there was enlargement, expansion of the brain stem and the bones, and was narrowing of the fourth ventricle. In contrast studies, there is a focal, I think there's focal area of enhancement in the left side. It could be this. I think I will going with brainstem glioma, the first for me, glioma in this region.
Yeah,
For this
right. So
I am suggesting it could be this focal necrosis, something like this, or myelinosis, something on top of this pathology.
yeah. Okay, yeah, so good. So this is the location, and you can see how different it is. This is really centered in the brainstem, very midline, with an area of enhancement, and possibly represent we have central necrosis as well. So quite heterogeneous signal lesion. And this is a diffuse midline glioma. It's a malignant lesion as well. So WHO grades, the higher the grade, the more malignant, the more dodgy or malignant the lesion. So grade 1 is benign. They say you get this classic triad of cranial palsy, lung tract signs, and ataxia. I don't think I've seen one clinically, at least in my in my practice. But I think it's the location that's characteristic. Okay. T1 hyperintense, T2 homogeneous to heterogeneous with variable contrast enhancement. And similar like the other two that you saw earlier, you need to image the whole neuroaxis to detect CSF spread. Things to think about, I put in GBM, but to be fair, a glioma is a glioma. GBM's your classic one you think of as a thick, heterogeneity enhancing central necrosis. It doesn't really look like that. I put in polycystic estro because we always think about that when you are in the posterior fossa, but often they are a bit more cystic with a solid component and not so not so solid if you see here. And the other thing is that if it doesn't quite make sense, you got to think of something like a brainstem encephalitis. So is it an infective cause to this? Okay, so if it's more, so the location of the diffuse midline glioma is quite age dependent. If you are pediatric, you are somewhere in the brainstem or pons, and if you are towards the adults, it can be actually in the thalamus or in the cord as well. Okay.